Welcome everyone, and we'll. I'm have the honor to introduce our guest faculty researcher, and I'll do that now. Sheer Lerman Ginzburg, welcome. We're honored to have you here and to teach us about your work. Dr. Ginzburg is a senior research fellow in the Department of Public Health Sciences at UConn Health. Her research interests currently focus on environmental health and justice among underserved communities near busy roadways, particularly the impacts of air pollution on stress and depression. It'd be great if Stefan Schwander was joining us. She's trained as a medical anthropologist and a public health professional. She's dedicated to incorporating community engagement at all stages of the research project process, which I think you'll find evident here. And the mixed methods researcher, she's received her PhD degree in medical anthropology from the University of Connecticut, where she identified a new syndemic in Puerto Rico, the OVIDD syndemic. OVIDD refers to obesity, structural violence, political instability, diabetes, and depression. And perhaps we'll hear more about that. She completed her NIH-funded fellowship in implementation science at the University of Massachusetts Medical School, where she studied the correlation between mindfulness and mental health outcomes among underserved communities in the greater Boston area. She's co-edited several books, among them Foundations of Biosocial Health, Stigma and Illness Interactions, Stigma Syndemics, New Directions in Biosocial Health, and Gender, Health, Society in Contemporary Latin America and the Caribbean. So without further ado, it's hard to not have a long introduction for Dr. Ginzburg. And so Sheer, we'll turn it over to you. And I assume we could jump in with questions, or we can also wait and have questions and comments at the very end. It's up to you.
Okay, maybe at the very end, so I don't lose my flow.
Okay.
Okay, so thank you, Dr. Mulling, for that introduction, and thank you everyone for having me. I'm going to be sharing my slides. Okay. So as Dr. Mulling said, will be presenting some of my work on environmental health outcomes, particularly among populations who live in heavily polluted neighborhoods. So a little bit of background about environmental health. Air pollution is now the leading global cause of premature death and disease. A lot of that is due to the small particulate matter size of air pollution, which can infiltrate the entire body. 9 out of 10 human beings currently breathe air that exceeds the WHO's guideline limit for pollutants. And there are several causes for that: household combustion devices, motor vehicles, industrial facilities, and forest fires. And out of those sources, traffic-related air pollution, or TRAP, for motor vehicles is one of the most recognizable forms. And the most common type of TRAP is called particulate matter, which is a combination of liquids and solids, and is composed of different liquid chemicals, such as sulfates and nitrates. Ultrafine particles are a smaller type of particulate matter, and they have a greater distribution than regular PMs. And one of the things that has caught interest with ultrafine particles are some of the health effects, ultrafine particles and regular particulate matter alike. And there are both short-term and long-term effects to long-term exposure to air pollution. Short-term effects include headache, coughing, pneumonia, and skin irritation. Long-term effects include central nervous system issues such as headaches, cardiovascular disease, respiratory diseases, and impacts on reproductive systems like low birth weight. So a little bit more background about the health effects of UFPs. One of the things that makes them a little bit more dangerous than regular particulate matter is that due to their small size, they can enter the body through the lungs and translocate to the rest of the body. And because of that, they mediate a systematic effect throughout the body. One of the first studies to look at ultrafine particles was a community assessment of freeway exposure and health, or the CAFE study. And one of it worked in Boston between 2008 and 2012. And one of its biggest results was that it identified the associations between exposure to highway traffic air pollutants and cardiac health in communities near highways. However, even with CAFE and some of the other research that's been growing, it's still unknown if the effects of UFPs are preventable or reversible. And to date, there have been no interventional studies on ultrafine particles. So the CAFE study, because of the lack of intervention studies, the CAFE team decided to develop another study, HAF-TRAP, the home air filtration for traffic-related air pollution. It's a study that I've been working on. And HAF-TRAP identified a need to carefully evaluate the health benefits of in-home air filtration as they become more widespread. Air filtration has been shown to reduce particulate matter from traffic indoors in both schools and homes. However, there's been little scientific evidence of efficacy for indoor air filtration. And it was for that reason that HAF-TRAP was designed. So the study plan for HAF-TRAP, which has been under the guidance of Dr. Douglas Brugge, has been to determine whether reducing exposure to air pollution by use of an in-home air filter is beneficial to health. It started in September 2019 and is very interdisciplinary. So we've been working with environmental health practitioners, civil and environmental engineers, and social workers, and the NIH, which is the funder. And we've been working for several things: measuring cardiovascular health, measuring air pollution, and conducting qualitative interviews. So the first aim of HAF-TRAP is to test the effects of HEPA filtration, and HEPA stands for high efficiency particulate air filtration, on biomarkers of cardiovascular risk for adults who live near urban highways. And for this study, the urban highway is I-93, which runs from Boston all the way up to Vermont and New Hampshire. And we've been enrolling 210 participants in a double-blind randomized crossover trial of 30-day periods with real or sham filtration, separated by a 30-day washout period. And the intervention is performed during the colder months. We've been working primarily with people who do not have central air in their homes. So during the colder months, people keep their windows closed, which is why we're running during the colder months. And the hypothesis for this aim is that HEPA filtration intervention will be associated with indications of improved health, primarily blood pressure and IL-6 inflammation. Our second aim is to assess the intervention success in participant homes. So we've been measuring particular pollution levels inside and outside of our relevant sample size of 15% of the homes. We've been assessing indoor time activity patterns, and we've been using quantitative and qualitative questions to evaluate how participants respond to the intervention. And our third aim is to assess biomarkers that can be used to suggest biological pathways. So we've been primarily around cardiovascular disease. So we've been measuring D-dimer, central blood pressure, and arterial stiffness. And we've been also looking at metabolome analysis. And we're using AIM-3 for future plans to see whether UFPs are associated with antioxidant pathways, in vivo generation of reactive oxygen species, and processes critical to vascular function. So a little bit about our methodologies. We're a community-based approach with community partners, the Somerville Transportation Equity Partnership and the Welcome Project. And we're located in the city of Somerville, which is right outside Boston. It's the most densely populated city in New England. And even though over a quarter of Somerville households use public transportation, only 15% live within walking distance of public transportation stops. And Somerville also has a large population of lower income, non-English speaking residents who live close to the highways. So this map over here is a general area of Somerville. So if you look at the yellow and red areas are the closest to I-93, which is right here. And all of the areas within this dark purple line on both sides are households who live within our study area, which is within 200 meters. So it's a good size, it's a good chunk of Somerville. So recruitment and retention, as I said, we're focusing on homes within 200 meters of I-93. We have a preference for apartments in buildings that are no taller than 3 stories, with windows that face the highway and like mechanical ventilation systems of central air. And we were about to start enrollment and recruitment when COVID hit. So to mitigate any of the dangers of in-person recruiting and interaction because of COVID, a lot of our outreach and recruitment have been online. So we've been doing online networking and distance flyering, and coordinating with the Welcome Project to advertise over listservs and Facebook and other online platforms. A little bit about our data collection process. So our recruitment staff would go door-to-door knocking once COVID restrictions lifted a bit. And we also advertised through flyering and the online groups. People would reach out to us and we would conduct informed screening and the HIPAA forms. And then we would do a baseline survey, which includes mostly demographic questions: age, sex, ethnicity, education, asking about furry pets and smoking. We would install the equipment with primarily the air filter. It's about the size of a small filing cabinet. And then we would also ask follow-up questionnaires at 4 different points, asking about whether they open the windows, what kind of heating they're using, cooking, whether they're vacuuming or lighting candles, and other associated questions, just to get a sense of what kind of activities people are doing while they have the filters in their homes. Okay, and people have the filters in their homes for 3 months. And we've been aiming for about 30 people enrolled at any time. It's rolling recruitment. And households are randomly assigned to either HEPA or sham filtration. And for the first 30 days, they're randomly assigned to one or the other using a computerized randomized algorithm. And participants have one air filter in their bedroom and the other one in their living room. Those are the 2 rooms where people tend to spend the most amount of time. And after the first 30 days, people have a washout period, and then followed by another period in which they will receive the alternate filtration, either real or sham HEPA. And to maintain participant blindness, we run the units without filters during the sham periods. We also collect biological data, and we work with a professional phlebotomist who goes to the people's homes whenever a project manager goes to install the air filters. And she collects the blood work in hallways or other open areas, mostly due to COVID safety precautions. And she collects about 10 milliliters of blood from each person. And at the same time that we're collecting the blood and we're measuring the blood pressure, we also collect height, weight, waist circumference, and hip circumference. So we measure the seated blood pressure 3 times for each visit. Okay. And we also evaluate people's experiences with the filters by means of qualitative interviews. So we want to assess the acceptability and feasibility of the in-home air filtration from the participants' perspectives. And are contacted via telephone and invited to participate in a 15 to 20-minute interview. So we asked them about motivation, logistics, and perceptions of the experiences of participating in the study. And what we found so far is that we've gotten some good feedback from participants, the participants about the noise levels of the filters and how much electricity the filters use because they plug into an outlet in the wall. So our current status. So we've enrolled about 45 people so far, and we're still enrolling people. We're enrolling new participants until the end of March, and we're also still scheduling in-home air monitoring and qualitative interviews. And due to COVID, our first cohort, which we collected last winter in 2021, was only a cohort of 16 people. But I did still want to give everyone an idea of the kind of data we've collected. We've really collected, we have a diversity of people in terms of gender and ethnicity. We've had a wide range of people from different ethnic backgrounds, education backgrounds, employment status, and annual household income. And the weight and BMI and central blood pressure are relatively average for the area. So based on the work that we're doing in HalfTrap, I personally developed a side project that assesses the effect of in-home air filtration on depression, anxiety, and perceived stress, primarily because mental health is one of my research areas. And I am adding several mental health surveys to HalfTrap. There's the CESD for depression, the PSS for stress, and the STI for anxiety. And I will be administrating these tests at 4 points in time where participants have the air filters in their homes, working with the same cohorts who live near busy highways, and asking the participants follow-up questions about how their mental health is doing while living in neighborhoods with high levels of air pollution and having the air filters in their homes. What we found so far, what I found, is that there's little scientific evidence on the associations with mental health outcomes and ultrafine particles. And one of the things I wanted to do with this work was to identify how geographic communities affect health. And I'm currently designing an NIH grant for this work. I haven't quite identified which mechanism yet, but that's in process. So future research projects. So all of the work that we are doing with HalfTrap and with my personal work on mental health in air filters, as that's several possible pathways for future work. All of these projects focus on either health disparities, mechanisms and biological pathways, or understudied causes of pollution. And all of these pathways, these projects, lead to prevention and therapy with some novel emerging technologies that can be accessible and cost-effective. Okay, so pathway one, the first research direction, focuses on health disparity and diversity. A little bit of background about environmental health and disparities. Environmental factors can and do lead to disease and health disparities in places where people live, work, learn, and play, especially in places that are burdened by social inequities. Hispanics and non-Hispanic Blacks are more exposed than non-Hispanic whites to airborne particulate matter, such as chlorine, aluminum, and elemental carbon. And living in public housing, which tends to be closer to busy roadways, is associated with environmental tobacco smoke. For example, 22% of children in public housing have asthma, compared to only 7% of children in single-family homes farther away from the highways. And in 2019, soot exposure, with soot being a form of particulate matter, soot exposure in the US was much higher for Asian Americans, Blacks and Hispanics and Latinos than it was for non-Hispanic whites. So there's a big correlation between environmental health and health disparities. And part of that correlation focuses on geographic vulnerabilities. As we're finding with half-trap, living with 200 meters of busy roadways increases the risk for asthma, dementia, hypertension, and diabetes. And these neighborhoods tend to be lower socioeconomic status, be noisier, and have lower land value, and tend to be populated with minority populations. For example, Hispanics and non-Hispanic Blacks are more than three times more likely to be breathing polluted air than non-Hispanic whites. And one of the things that I found is that there's very little evidence on air pollution in immigrant majority neighborhoods. And that's another direction of research that I wanted to undertake. And specifically New Jersey, this is an area of unmet need and opportunity for both further research and for interventions, primarily. Last year, the American Lung Association published its 2020 State of the Air report and found that New Jersey has some of the worst air quality in the country. 8 out of 21 counties in New Jersey, including Middlesex County, received an F for the number of days when they violated the nation's air quality standard for ground level ozone. However, New Jersey has made some significant improvement, specifically for meeting the standard for particulate pollution a few years ago. So things are improving. So pathway 2. And this is the area that I'm currently in the process of developing. It focuses on other forms of pollution, such as noise, chemical, and light pollution. There's often an interaction between different pollution types, and we need joint interventions in order to treat them further. So this is an area where I'll be developing projects on, for example, air pollution and noise pollution, since communities near highways that tend to be exposed to air pollution also experience high noise levels from the same cause. And pathway 3, mechanisms and biological pathways. These include pathways such as pulmonary function, sleep quality, and stress, and endothelial function. And hopefully these pathways are modifiable, and they can help us identify novel and effective therapeutic targets. In order to elucidate some of the biological pathways, we can identify novel biomarkers, such as cortisol, to measure stress among people living in heavily polluted areas, and measuring cholestanoic acid, which is a new biomarker that can be used to identify acute respiratory distress syndrome. And we can also discover innovative targeted preventive and therapeutic measures, such as pulmonary tests and sleep quality. And sleep quality has been very clearly identified as being correlated with worse overall health outcomes. So studying quality of sleep can also identify respiratory health and respiratory distress as well. And it might help us identify other unrecognized risk factors. And we can also use these mechanisms and pathways to develop novel and emerging technology for prevention, such as AI prediction, which uses big data to build models to predict and identify at-risk populations and individuals, and also use novel remote screening, which can be used to identify biological signals for vocal and facial features. And these can help us develop and design lifestyle modifications. And they can also be implemented over social media, which can help us identify vulnerable populations and do remote screening for biomarkers, which can be very useful during the pandemic. And we can also use these developments to introduce novel devices and equipment, such as for white noise, that may allow us to minimize the impact of various sources of pollution. And one of the ways of doing this is to partner with engineers and other interdisciplinary partners to realize innovative changes. And on a more global level, one of the projects that I would like to develop is to work in San Juan in Puerto Rico, which is where I did my dissertation work, to assess environmental health and stress post-Hurricane Maria, which hit Puerto Rico in September 2017. Hurricane Maria destroyed Puerto Rico's air monitoring systems, which made people rely on backup generators for months. And this put significant pressure on fuel supply chains. Currently, about 44% of the population lives below the federal poverty level, and many of them live near busy highways. And a lot of Puerto Ricans face significant confounding health conditions such as asthma, diabetes, and hypertension. And one of the things I would like to do is to compare the air quality and stress outcomes with Puerto Ricans living in New Jersey as part of a question about how do members of the same population differ based on geographic location. Okay, so a little bit of summary. As I've said, ultrafine particles are hazardous to human health, and air filtration is an affordable yet understudied method of mitigating UFP exposure. There are potential correlations between air pollution and mental health with outcomes which are unexplored, and there are multiple possible pathways for further investigation, including health disparities, more biological pathways, other forms of pollution, and also doing global work in Puerto Rico. Several acknowledgements: Dr. Douglas Brugge, Linda Sprague-Martinez, and Ellen Reisner. And thank you. And if anyone has any questions, I include my email here so people can feel free to reach out to me with any questions they might have.
Great to do a round of applause, and those can do a virtual round too. I think we can, we have the reactions we can put in our corners, corner of our Zoom screens. But thank you.
Thank you.
Thank you, Cher. Let's have this open for questions or comments. I had one, but the crossover design answered my question in terms of when COVID-19 came, did you go back to your IRB? Because HEPA filters would seem to be useful in a household setting, but the crossover, I guess, makes it equal exposure or non-exposure to the HEPA filter.
And
go ahead.
I will say that when we started doing the qualitative interviews, a lot of people informed us that the reason why they decided to participate in the study was because they thought the air filters might help against COVID. So whether or not that's true is another question, but it was a motivation for people to enroll in the study.
It's interesting you bring that up, because I know the group in Yoshi here at Rutgers has been actually studying the role of HEPA filtration, and I think they have another machine to add in COVID, looking at the COVID risk with those types of filters. But I had a question also that, so your project is the HEPA filter is placed versus the sham filter for about a month or 2 months, or I may have missed that.
Yep. So it's the actual filter is placed in people's homes for 3 months. For the first month, they will get either sham or HEPA, which is really just whether or not they have a small filter within the larger filter. And then the second month, there's nothing there, it just sits there off. And then the third month, they get the opposite. So if they had HEPA at the beginning, then the third month they'll get sham.
The crossover. So the question I had was, in the hypothesis that 1 month of filtration would have an impact on the health measures that you were looking at? Is that long enough? Is my question. And
Right.
some things are so long-standing.
Right.
You know,
That's a good question. And because there hasn't been a whole lot of research on this topic before, we think that that's enough time. We think that that might make a difference. And we won't know, obviously, until we finish collecting the data, because we're only about halfway through, and our first cohort was very small due to COVID. So far, from what I've seen, the blood pressure of people, and blood pressure being one of the primary markers for our study, blood pressure has gone down. I couldn't tell you how much because we're still analyzing that data. And I think that this is one of the points of the study that we can say, okay, maybe 1 month is not enough. Maybe it needs to be running for 6 months or a year. And we're not entirely sure yet, but hopefully it's at least long enough for us to see some sort of change.
thank you.
What's striking to me is this, how many people are affected by basically air pollution, but then it's kind of obvious, but it's less studied how it is a huge health inequity just by location.
Yeah.
And lastly, what to do about it. We can do all the descriptive studies and identify health inequity, but it's great to also say, well, let's look at interventions and let's test interventions.
Right.
Is really great.
Yeah. Air pollution is incredibly pervasive. And, as you said, it's easy for us to say air pollution is dangerous, but we can't pick up a whole neighborhood and physically move it to somewhere else. It's a bit harder to do. So that's one of the points of the studies, to at least try to identify smaller scale interventions that we can do to help people. And the air filters that are available can be incredibly affordable, which is important for a lot of the lower income populations that we're working with.
Yeah, I was surprised by that, as we have a program for COVID-19 and for small businesses, what to do with businesses, especially businesses. They don't have extra money to spend on pretty much anything, and but the air filtration was surprisingly affordable, comparatively. So it would be good to study, as Sunanda said, as Yoshi's doing, or others, how effective are the HEPA or other maybe less expensive, although the HEPA is not that expensive, but there's certainly less expensive filters versus just air ventilation, even though you have the windows closed in the winter, versus other things. It's really understudied now that we have COVID.
Right.
It's more important to study it too.
Yeah, absolutely. Primarily, specifically because of COVID, I think, especially at the beginning when people were spending more time in their homes, and the air quality outside was getting better because people were not driving as much. So that would have also an interesting point of study. And stressful, I think. A lot of the people I've talked to during the study they're well aware that they live in very air polluted areas. And some people have told me, yes, we open the windows and then we can see soot coming in and staining our windows. So people are very aware of the air quality in the neighborhoods, and what to do about it has been very stressful.
Mm.
Especially the households that have children who are walking outside and there's nowhere for them to play, and how to get to school in a healthy way. So it's
Mm.
stressful.
If I may jump in, I was intrigued by your mention of Puerto Rico and your desire to go back there and research mental health. And we, as the Institute, after Hurricane Maria happened through our focus area disasters, community health and resiliency, we actually sent a delegation there multiple times to see how people were doing and to really learn from what does the community need. And we worked with community members. We started, we helped with the community garden because vegetables were not available, because we learned that they import export everything. Yeah. So, and then we also got in conversations about mental health. So maybe you could you elaborate a little bit more what you're hoping to do there?
Right. That's a good question. So I did my dissertation work in Puerto Rico, but that was before Maria. And even then, I was based in the diabetes clinic, and a lot of the people that I talked to, whether they were at the diabetes clinic or elsewhere, reported very high levels of mental health issues. So a lot of people were struggling with depression and stress and anxiety. As you said, about 80% of Puerto Rico's food is imported, and that adds extra tax. It adds, the food is taxed, so it raises the price of food, which further, stress people out even more. And Puerto Rico is in this very legally and politically ambiguous area due to its status as a US colony. And one of the things that I wanted to do, and I've also been in contact with my colleagues in Puerto Rico since after Maria. And one of the things that I wanted to do was to continue following the mental health outcomes and talk to people about how their mental health has changed since Maria, and then also since the pandemic started. That I think particularly now that things are opening up a little bit more and tourists are starting to fly down to Puerto Rico again. A lot of Puerto Rico's economy is based on tourism, but at the same time, a lot of the tourists have not been adhering to the same COVID standards as people who are living there, which has added extra stress and antagonism, I would say. So I wanted to measure some of the mental health outcomes and then ask about air quality as well. Now that things are starting to clear up again and there are more flights, and a lot of the people I talked to were very car dependent, partly due to the heat and then partly due to just the public transportation system in San Juan not being consistent. And I'm saying there's someone who lived there and had to rely on the bus system as well when I was there. So I wanted to measure health and maybe do a similar study to what we're doing in Somerville right now with air filters in people's homes. And that's something that I can also do with Puerto Ricans in New Jersey. And also ask people about some of the health disparities they're facing, particularly around food, which, as you mentioned, with community gardens, that food access has been a major point of discussion as people are struggling to afford food on a regular basis and then trying to identify other sources of food, community gardens and microagriculture and whatever other means possible. Yeah.
Thank you.
And this project is a little bit farther down the line. So there's room for a lot more precise development of some of the tools and measures I'll be using.
Great. Well, any other comments, questions? Well, Shir, thank you so much for a very interesting description of your study and future studies and future directions. whether they be in the U.S. or Puerto Rico is part of the U.S. It's territory, but it is distinct and unique, and a wonderful place to both live and work. We also loved having our project in Puerto Rico because we thought about opening Rutgers down south, but they already have a good school of public health and lots of other good schools. So we partnered with the School of Public Health there and others in Ponce. And but thank you so much for presenting here, Sharon, and thank you everybody for joining. And we'll have this recorded, as you can see, so it'll also be available online at our website, and for others that may have had some login problems, we're not sure, but thank you all for joining us, and have a great afternoon. Thanks again, Dr. Ginzburg.
Thank you, everyone. Thank you.